Hi there. So you've struggled with learning pressure volume loops or learning about cardiac output and venous return curves. Well, you're not alone, and today we're going to try and correct that problem for you by going through the basics of each of those two kinds of loops and looking at the various axes and underlying principles, and then we'll let you take off on your own using them for real clinical work. So let's start talking about the pressure volume loop. And the pressure volume loop is a way of looking at the cardiac events in themselves and understanding how they relate to preload, afterload, and contractility. So the way we're going to do this is we're going to start out by looking at the axes and the reference lines, just so we know what the axes and the reference lines are on these diagrams. Then we're going to talk about the loop itself and talk about the valvular events and the phases of the cardiac cycle that we're looking at as we go around the loop. Then we're going to come back and talk independently about contractility or inotropic state. We're going to talk about preload, or how full the ventricle is, the end diastolic fiber stretch, if you will, of the heart. And then afterload, which is the pressure that is being developed during ejection by the left ventricular muscle. And so with each of these three things, we can pretty much identify the functional state of the heart. And that's why pressure volume loops are going to be so interesting for us. I'm going to then come back and do a little addendum where I'm going to talk about afterload and its relationship to total peripheral resistance, and remind you that afterload is something different than total peripheral resistance. And then we'll look a little bit about stroke work and remind us about remodeling of the ventricle as we look at pressure volume loops. So with this in scope, let's get started. So let's talk about axes and reference lines, since we've got a couple grids here. And on the first graph here, let's make sure that we remember that the x-axis is left ventricular volume. Okay, so as we move to the right on this axis, the volume is increasing, and obviously as we move to the left, the volume is decreasing. The y-axis is pressure in the left ventricle. Okay, so we have pressure on this axis, and as we move up the axis, pressure is getting higher, and as we move down the axis, the pressure is getting lower. So the next thing that we have to do is to talk about our reference lines, and the first reference line we're interested in is the diastolic filling line that looks something like this. And crudely speaking, the diastolic reference line tells us what happens to diastolic pressure and diastolic volume in the relaxed left ventricle as it is filled during the process of charging it up, if you will, to get it ready to contract. And you remember that filling is roughly into 3/3. The first third is the rapid ventricular filling, and there's a diastasis period, and then there's an atrial kick component. And so as we move along this line of filling, those three things will happen, and we won't use the whole line in any given cycle. We'll use just a part of it, and those three phases will be the three phases of the part of the loop that we're looking at on the diastolic filling line. And now let's talk about the second reference line that we need, and this is the so-called end-systolic pressure volume line. And that's a line that usually is drawn fairly straight and over on this part of the diagram, and it's got some slope to it. And the important thing to notice about the slope of the end-systolic pressure volume line is that it represents contractility. And so that if contractility goes up, the slope of this line becomes steeper, and as contractility goes down, the slope of this line becomes more shallow. And so you don't need to know exactly where this line is, but what you have to appreciate is that this is a measure of contractility, with orange being a low contractility and green being a high contractility, with the black line being normal. So the next thing that we need to do is to think about what does the pressure volume loop look like relative to these reference lines. So we have to start somewhere, and we're going to start at the point at which the mitral valve just opens. And when the mitral valve opens, we get filling of the left ventricle. So first we get rapid ventricular filling. Then we get a period of diastasis where it doesn't move much along this curve. And then we get an atrial kick that puts the last 30% or so of blood in there. Now the QRS complex comes in and the left ventricle begins to contract. And when that happens, the mitral valve closes. Now both the mitral and the aortic valve are closed, so even though the heart is squeezing on the blood inside, the volume of that blood isn't changing, but the pressure of that blood is changing, and so we get no change on the volume axis, but we get an increase in pressure up until some point. And that point is the point at which the pressure inside the ventricle exceeds the pressure in the aorta, and then the aortic valve pops open. So at some point where the ventricular pressure just exceeds aortic pressure, the aortic valve opens, and now the ventricle is connected to the aorta. The heart continues to squeeze, and as it does so, it squeezes blood out of itself. How far? Until it hits the end systolic pressure volume line. And you just got to learn this, that it ejects how far till it hits the end systolic pressure volume line, and then it isovolumically relaxes again and begins this whole journey of filling again. So that is our classic pressure volume loop. And so let's take a look. We get mitral opening, rapid ventricular filling, diastasis, atrial kick, isovolumic contraction, opening of the aortic valve, rapid ejection, reduced ejection, aortic valve closes, and then isovolumic relaxation. And so during the isovolumic contraction phase and the isovolumic relaxation phase, we find out that the aortic valve and the mitral valve are both closed in each condition. So the only thing that changes is pressure. So next we need to deal with the issue of inotropic state or contractility and how that's going to influence the pressure volume loop. And we've got for reference here our initial pressure volume loop. And if we're going to draw on top of this loop, what we're going to do is we're going to start again with mitral valve opening. And we're going to fill to diastasis. And then we're going to fill some more with the atrial kick until we get to the point that the QRS causes the heart to isovolumically contract. The pressure is going to build up just like before in the left ventricle, and we're going to build up to exactly the same pressure if the afterload hasn't changed. If the pressure at which the aortic valve opens is still exactly at the same diastolic pressure before, the aortic valve will open at the same pressure as before. And now blood will leave the ventricle, and it will leave until when? Until it hits the existing end systolic pressure volume line. And what you'll remember is that the slope of the end systolic pressure volume line is steeper if the contractility is up. So if we have an increase in contractility, we'll go over to the green line rather than the black line before we isovolumically relax. And then once again, sort of the aortic valve closure here and mitral valve opening here rather than where it opened before here. And so what we notice is that the end systolic volume before was right here, but the new end systolic volume, let's see if we can do this, the new end systolic volume is here. And so end systolic volume decreased when contractility went up. What are the implications of that for what's going on with the curve? Well, our initial stroke volume was the width of the initial curve. And so that was our initial stroke volume under normal conditions. When the contractility goes up, our new stroke volume, the width of this, is now this. And you'll remember stroke volume is equal to end diastolic volume minus end systolic volume. So it's the width of the pressure volume loop. And what we see is that the width got bigger because we were subtracting a smaller number from end diastolic volume, and therefore stroke volume, if this one goes down, stroke volume is going to go up when contractility increases. So that's it for inotropic state. Let's move on to preload. So next we need to talk about preload, or end diastolic fiber stretch, or the amount of filling that is in the heart, and see what happens if we increase that. So you'll remember we're going to start once again with mitral valve opening here, and blood is going to fill along into the heart. We're going to have a short period of diastasis, and then filling is going to continue with the atrial kick. But now we're assuming that we get an increase in filling because we had an increase in venous return or a stronger atrial kick or something, which means that our end diastolic volume, which is another way of thinking about preload, is higher than it used to be. We've moved farther to the right on the diastolic filling curve. The QRS complex comes, both valves are shut, so we isovolumically contract how high? Till the ventricular pressure just exceeds the pressure in the aorta, and the aortic valve is going to open. We're going to eject how far? Over to the end systolic pressure volume curve, and again, we're assuming that's sort of where it was before on the black line. We're at a normal contractility, and then we isovolumically relax, just like we did before, and the mitral valve will open again. So the big thing that changed was where the mitral valve closure occurred. Okay, the mitral valve closure occurred at a higher preload, and so now our stroke volume, again remembering that it's end diastolic volume minus end systolic volume, is higher than it was under the normal condition where it was this red width that we were looking at. But this time, the reason it is wider is not because end systolic volume has decreased, but because end diastolic volume has increased. And the end result is that an increase in preload has increased stroke volume. And for those of you who remember, or all of you should remember, that's Starling's law of the heart. So Starling's law. Of the heart is that an increase in preload gives us an increase in stroke volume. And the pressure volume loops show us why that's so. Now we have one more thing to talk about, and that's changes in afterload. Remember, afterload is the pressure in the ventricle during the ejection phase of things. And it's going to be initially seen as the pressure at which the ventricular pressure just exceeds the aortic pressure under normal circumstances. And so imagine an increase in afterload as an increase in aortic pressure at which the valve opens. And so under normal circumstance, what we saw was that the pressure at which the aortic valve opened was right here. So let's look at what happens if aortic pressure is higher than normal, i.e. we have a higher afterload than normal. So we start with mitral valve closure over here, like we have in the past, and so we're at this point. And we fill the same as before, so about 70% of the filling happens. And then the last 30% happens during the atrial kick, with a little phase of diastasis happening in between the two of those things. Then the QRS comes, and as the QRS comes, the ventricle begins to contract. As the ventricle begins to contract, its pressure just exceeds the aortic, atrial pressure, and the mitral valve closes. We started over here with mitral opening, I'm sorry. The mitral valve closes, and now we get isovolumic contraction up until aortic pressure. But we said, let's imagine that we have a higher aortic pressure than we did before. And so now what happens is the ventricle has to contract to a higher pressure to push the aortic valve open because now there's a higher initial afterload. We eject how far till we hit the end systolic pressure volume line. And notice, because we're higher up on a slanted end systolic pressure volume line, we hit it at a higher left ventricular volume than we have been hitting it in our previous slides. And so when we isovolumically relax here, you see that we come to this point. We didn't get as much blood out. And so this point is our end systolic volume when we're at a higher afterload, whereas our end systolic volume at the lower afterload was down here. So we remember that stroke volume is equal to end diastolic volume minus end systolic volume. And what we see is end systolic volume is up, so that the difference between these two is less than it was before. So what we see if afterload is up is a decrease in stroke volume. So we see that on the curve then, as the curve is skinnier than it used to be in comparison to this one, which we saw under normal circumstances, where we had a higher stroke volume than we do now, the stroke volume when we have an increase in afterload. So we're going to talk about just a couple other things related to this in our addendum section. And now I'd like to talk about just a couple issues which can become confusing to students. And the first is, we said that afterload is basically the ventricular pressure, which is about the same as the aortic pressure during ejection. So you can think of hypertension, for example, being an increase in afterload. What some board books do, which will become more confusing with cardiac output and venous return curves, is they treat afterload as if it's actually total peripheral resistance. And this is just not an accurate way to talk about afterload. So just to remind you about the relationships between pressure, flow, and resistance, we can draw our triangle to help us remember Poiseuille's law, writing things in alphabetical order, P, Q, R, where pressure is P and Q is flow and R is resistance. And you cover up the one you want to solve for. In this case, afterload is a pressure, so we want to cover up the P, and we see that it is the product of flow, Q, and resistance. So mean arterial pressure is the product of cardiac output, which is our flow, and total peripheral resistance, which is our resistance. And what I said is some board books assert to you that if total peripheral resistance increases, then afterload increases. And that's true if the only thing that happens is total peripheral resistance increases. But often in true life, what happens is total peripheral resistance goes up and you get a simultaneous decrease in cardiac output, and therefore mean arterial pressure or afterload don't change a bit. And so when we get to cardiac output and venous return curves, I want you to separate in your head resistance, which is one thing, it's about blood vessels, and afterload, which is a pressure and is about the heart. So afterload is related to hearts, and total peripheral resistance is related to blood vessels, and that'll be important when we talk about cardiac output and venous return curves. When we get valvular disorders, one of two things can happen to the pressure volume loop. It can get wider or it can get taller. And so what I want to do is remind you that if we look at the area under the pressure volume loop, that is, you can think of it as a box. Pressure times volume is the area under the pressure volume loop. We call that stroke work. So stroke work is the product of pressure and volume. And there are two ways that you can end up getting an increase in stroke work. One is that the loop can get wider, either because of an increase in end diastolic pressure or a decrease in end systolic pressure. And so we would have something like this blue loop here has a wider area to it. And so you can see that the area of the blue loop is bigger. The stroke volume, stroke work of the blue is greater than the stroke work, is greater than the stroke work of the red, okay, because the loop is wider. And when the stroke work goes up because the loop got wider, okay, so wider, the type of hypertrophy that we get is so-called eccentric hypertrophy. That is, the lumen of the ventricle gets bigger. The wall thickens a little bit, but the major thing that happens is that the lumen goes from this to something bigger than that. The other kind of thing that can happen to the ventricle is that instead of getting bigger because it got wider, is the area can get bigger. Can get bigger because it got taller. Okay, and I'll put a little thing here. And again, we see that the area of this pinkish loop is greater than the red loop, but it's because it got taller and not because it got wider, okay, as we saw before. And so if taller is the reason that we get an increase in the stroke work, we get a different kind of hypertrophy, and that is called concentric hypertrophy. And the hallmark of concentric hypertrophy is if we have a normal ventricle, we're looking down on the top with this sort of wall thickness. What we get is a new ventricle that has about the same size lumen as we had before, but we get massive wall thickening. So this is concentric hypertrophy with massive wall thickening in comparison to very limited change in the size of the center. Whereas before, when we were looking at eccentric hypertrophy, and I didn't really draw them, the wall has some thickness, and when it gets bigger, let me redraw that. Let me redraw this. Uh, uh, the chamber diameter gets bigger, but the wall only modestly thickens in comparison to what happens to the thickening in concentric hypertrophy. So it's mainly the lumen here that changes in eccentric hypertrophy, whereas the wall thickening that happens in concentric hypertrophy. So that just reminds us a little bit about how pressure volume loops can see. When I've drawn them over here for talking about this last issue, I've drawn them at the same pressure and volume. And there's a really nice paper from the 70s from Sandler and Dodge that actually will show you that they, in both insufficiencies, the total volume, both systolic and diastolic, is up, as well as the loop getting wider. Whereas in concentric hypertrophy, we mostly get an increase in the height of the lumen. And that has to do with changes in compliance that happen to the ventricle. And notice the one disorder that doesn't cause ventricular remodeling. So we see this top in mitral insufficiency, mitral regurg, and aortic insufficiency, aortic regurg. You could likewise, you'll see it in tricuspid on the right side, insufficiency, but for the right ventricle, and for pulmonic insufficiency on the right side. The one that makes it taller is aortic stenosis. And the disorder that's missing here is mitral stenosis. Why is that? Because stenosis of the mitral valve, and likewise tricuspid stenosis, causes blood to be less likely to get into the ventricle, so it neither increases pressure nor increases volume, and so the stenosis of the atrial AV valves is not associated with hypertrophy of ventricular muscle. Okay, so that's a short of how pressure volume loops can help you think about hypertrophies. And that should be pressure volume loops in a nutshell.